the TL line out correctly. And if you're laying on your stomach, they go into flexion. If they're laying on their back, it pulls them into extension. So just make sure you know it. One of the things that I'd like for you to do is to read through chapter 12 in this book. It's everything pretty well that we've covered for quadriplegia, and you may be responsible for some things I don't cover. It really goes right along with what we're doing, the MAT activities. I've got some good pictures in here. She's doing a good example of doing some different things, even though she's not a quad, I don't think. But long sitting, how you do quad lifts, different things. And then today we're going to do self-range of motion and then some ambulation for your.
What book do we need today?
This right here. Okay, we're going to do spinal cord injury on the second part and just go over some things that actually came out of this book. Autonomic dysreflexia is a term that you need to be aware of, and it occurs in patients with injuries usually above T6. And what happens is their blood pressure goes crazy. Sometimes it'll shoot up, sometimes it'll drop. A lot of times this is caused by bowel distension, but more than likely you always check the catheter to make sure it's not kinked. That is the first thing you always check if someone's going into autonomic dysreflexia. Usually the symptom that you see with this is severe hypertension, but sometimes you do see hypotension. And again, they look really bad. Causes are bowel distension, they need to have a bowel movement, bladder distension, any kind of pressure sores and they're getting pressure on it.
Do you have this where we can print that off?
Yes, yeah, it's under rehab. It's your top one under spinal cord injuries.
It wasn't there earlier.
Yeah, it's been there. It's been there the whole time. But not there?
No, I printed it off a long time ago.
I got spinal cord injury.
It's not there? Well, let me see if I don't.
It's there.
Do you care if we print it real quick, Ms. Sherry?
No, I don't. Print it away. So a lot of things, the other thing I want you to look at is environmental temperatures. One of the things, and you need to write this down, that you have to realize with these guys and gals, is they cannot tolerate our summertime. They can't go out and watch a ball game. Sometimes your paraplegics can't do that because they do not sweat below the level of injury. So if you have a quadriplegic that's a C6 injury or a C5 injury, they're not sweating below their shoulders. So what can happen? They can die, and they do. If they go into autonomic dysreflexia most of the time and just get overheated and it can kill them. So that is something that they have to be very is what's going to
Is
kill
that
them.
just the upper motor neuron that don't sweat below the injury, or?
T6 and above
Okay.
is normally where you see it. And what they normally do too is you'll take a spray bottle with them if you take them out somewhere, but you just have to be very aware of that because you don't want them to do that. Sometimes it'll even come on with passive stretching to the patient's hip. So you just have to look at that. Any questions on autonomic dysreflexia? I've seen it happen on the tilt table.
I got one.
Bringing them up. Sometimes they'll be sitting in their chair. They'll just go into it, and they know it's coming on if there's someone who one have to deal with it the rest of their lives. And then you'll have those patients who don't have real issues with it too much.
So if it happens on a tilt table, does it go away whenever you lower them back down?
It'll go away when you, whatever's causing it, you stop the cause. So like if they're having, sometimes it'll be a bowel movement, or they need to have a bowel movement, or a lot of times though it would just be that the catheter bag is kinked.
Will it ever be just from raising them up there?
Not usually. I mean, it's just going to drop, usually if they're for hypotension more so, where this is usually more hypertension. things that happens, when you're looking at postural hypotension, remember that they don't have any, skeletal muscle action, and so this causes venous pooling. So one of the things you can do too, when you're getting them up into a wheelchair, is put the hose on them and 70 over 40. You really don't want them to get that low, do you? But some of these guys function at 90 over 60 all the time when they're good. So it just depends on what's going on with them. But ideally, you don't want them to get below 70 over 40. That would be very low. I'd put them down if they got down that low.
Put them down.
If I was on the tilt table, I would
Oh,
lay them back down. Or if I had them in a wheelchair, what you would do is you would lay them back on you just prop them back and recline them as much as you can. You might even put them all the way to the floor. Seriously, if they're going into where they're passing out on you. If you ever have a patient pass out in a wheelchair on you, that's what you want to do. You want to completely either lay them back on you, maybe sit in a chair or whatever, or you might put them all the way down on the floor with their head down and their feet in the chair, okay? So whenever someone passes out, you want to get them as flat as possible, right? So that's something you can do.
Would you be able to do that with the catheter?
Yeah, because all you're gonna do, as far as, you're just gonna lay them, you're gonna keep them in the chair, but lay, you're not gonna pull that back in. Some of the pain that you deal with, and, probably what, one thing that you always see is with lumbar injuries, like L1 to L5, they almost always have pain. And they'll have pain from now on. I don't know why, it just goes with those low-level injuries. So it's not even a phantom pain. Sometimes it's just a tingling and aching pain. And so that's something you deal with those levels of injuries.
Is it like a constant, or?
It's a constant pain. It's like a low back pain. That's what they'll tell you. Pain can come from all kinds of issues. It can come from being in a motor vehicle accident and damage. I mean, think about the trauma to the low back and the muscles when you fracture your low back anyway, or your neck, or whatever. So you're just dealing with some soft tissue issues on top of anything else. So there could just be a lot of types of pain. Phantom pain is also something else. They always, think they feel that leg, right? Or whatever, and it can be painful. Any questions on that? Anybody know any quads or paraplegics? Yeah, just, have you ever talked to them about their physical, how they handle things, or?
It's been a long time ago, but
Mhm.
it's been a long time, no, it's not really.
Contractures, that you can deal with and that you want, and we talked about this before, is you want to keep the hamstrings at about 100 degrees straight leg raise. You don't want to increase that. And why is that? What's the purpose of not doing that? Why do you not want over 100 degrees?
Are you using different muscle there?
Oh, for helping their trunk support.
Yeah, it's a trunk support thing. So even with a cerebral palsy child, what you'll do is they'll be sitting in the chair and they don't have any trunk support, and they literally can just fall straight over. So it helps them to keep their sitting balance. So you don't want those to be stretched over 100
That's what that one
degrees.
guy was talking about.
Yeah, if you want, we talked about that. That would be a C6, C7 injury. So that's called tenodesis, that tenodesis grip. This is a tenodesis, this is a tenodesis movement, just so you know. Because your hands, when you bring your wrist into extension, your fingers go into flexion. When you bring your wrist into flexion, your fingers will go back into extension. So that's a tenodesis.
Did you say C6?
Another thing that you have to deal with, especially with quadriplegics, is heterotopic ossification. Have y'all had that with your orthopedic patients? Sometimes pitchers, baseball pitchers will get that in their quadriceps. Anybody heard of that before? Anyway, that's another place that you see it, but you also see it in quadriplegics, normally in their hips, in their hip joints. And sometimes you'll see it in their knee joints. And it basically just calcium deposits in that muscle, and it grows bone in that muscle and around that joint.
Bill said like he's seen it like when athletes pull their hamstrings and it heals. He's
Severely.
seen it in the head.
Yeah, it can happen with an orthopedic injury in the biceps or at the hip.
Different name.
Yeah, what did he call
I
it?
don't think so.
Yeah, it's like myositis ossificans or
Oh,
something.
okay.
Yeah.
Okay.
Yeah, that's what he called it.
Tissue hypoxia, abnormal calcium metabolism, and then local trauma. And I've had a number, at least get up to 90 degrees, they have, where it develops that calcification, they'll break that up when they go in and do surgery. So I have had quads that have had this, because it messes up all their sitting balance. There's a young man in Spiro, he's probably 30 or 32 now, I can't remember. But anyway, he's a quadriplegic, he's about a C4, and I treated him when he was first, probably over 30. But he was completely paralyzed, he was like a C4 injury. He had, myositis, I can't think what it's called, but it's transverse myositis, where you can get a virus in your spinal cord, and it caused him to be paralyzed like a spinal cord injury, and that's what he is. Well, what happened is he decided to go to college, and that's when they were starting to allow, for you to do it completely on a computer, and he did that, and he got lazy. And he was spending like 5 to 6 hours up in a recliner instead of going all the way up. And so he developed that and had to have those broken up. So they really do need to be careful. And he was probably 8 or 9 years down after he had the accident. It wasn't really an accident, it was the disease process is what it was. Something else that can be a problem is the deep vein thrombosis in the lower extremities, which makes sense. Osteoporosis can happen, so especially if they don't get into weight bearing right. So then they become very easily broken in their lower extremities, and that does happen. Sometimes they'll break a bone and they're not even aware of it. So why is that an issue? What happens?
The bone can start repairing in malalignment.
Yeah, it does malalignment, but also their body eventually will react. They'll do something, autonomic dysreflexia, or, usually if you break a bone, eventually your body's gonna tell you. So they usually know within a day if that happens, just because they know something, renal calculi, which would be into the kidneys, and they have to really take good care of their kidney function. They have to drink plenty of water. They need to, all those different things so that they do that. Do y'all have any idea how they do bowel and bladder? How would a spinal cord injury do bowel and bladder?
Catheter and bowel cover.
Yeah, ideally, it's the healthiest thing for them to do is cath every 4 to 6 hours. But does that really work into very many people's lives?
Would they have like a suprapubis?
Yeah, a suprapubic catheter is probably the most common thing that you see them do, and because it's just the most functional. But again, they deal with a lot of bladder infections, and so UTIs sometimes are what kill them. I saw there. Any of y'all ever go into the Salisal Walmarts, or do you remember Joseph who used to work at Walmart here? Anyway, he's a paraplegic that I knew back in New Mexico. I did rehab. I was at the rehab center when he was rehabbed, and I saw him at the Salisal Poto football game this last year, and he had been in the hospital for 2 months with a UTI. And this guy is, I've been here 19 years, so he's like 22 years out. He's a T8 paraplegic. So those things, he also got a really bad bed sore that put him down for a long time. So they have to really be aware of those issues all the time. He really has a lot of UTIs.
What, did he have the suprapubic, or did he?
He has suprapubic, yeah. He started out cathing when he was a young man, and then he went to the suprapubic. He told me it just became too much of a hassle. Because they have to go to the bathroom, and they have to be able to do it in the toilet, or have a place to lay down, all those different things. Cathing is not an easy thing, and so it's the healthiest thing for them to do, but most of them go to a suprapubic catheter. And then most of them do a bowel program either by having like a suppository every other night, and they'll lay in bed and have a bowel movement, or else they'll sit on a, like do it every other morning, cushion under them, right? So if they're having a bowel movement for 2 or 3 hours and don't do a lot of good pressure relief, then they can have breakdown. So most of them actually do that in bed. So you have to deal with that as a family member. You understand how that's very difficult to do. And so your number of spinal cord injury females, what's the percentage do you think that lose their spouses? 50%
I
of
was just
females.
guessing, I didn't know.
No, but you're right, I'm sorry. 50% of men lose their spouses and about 85 to 90% of females lose their spouses. Because it is just so, it's just hard. It's just a completely different way of life. And
So, but it's not like on their ballot program, it's not like it's kind of like a long drawn out ordeal.
Well, it is, because you're looking at every other night, you've got to go to bed and do that. And then you'll do a suppository, and if you're paraplegic, you take care of yourself, right? But if you're a quad, someone else is doing that. So it's just kind of a hard thing. Remember with the respiratory issues, you have the segmental innervation of the intercostals from T1 to T12, so the lower they go, the more lung expansion they have. You still have that sheet that talks about functional levels, and it talks about the respiratory function that they have at different levels. Remember your diaphragm C3 to C5. Abdominals are needed for coughing. And we talked about the assisted coughing techniques. I did look it up on YouTube, and there are some assisted coughing on YouTube if you want to see that. There's a good picture in your book also of assisted coughing. And again, it's not uncommon for a high-level quad to have a binder or an abdominal binder or corset, especially if they're having a bad day. Sometimes they'll just put that on to help them to breathe better and everything. Oh, here's bowel and bladder dysfunction. Spinal shock, remember that your bladder is flaccid or areflexic initially. So how long does spinal shock last when someone's had spinal cord injury? About 10 days to 2 weeks. That's when they initially go in the hospital. So for sure, they're not going to be doing much for that amount of time. And what do they look for? What's the first thing that tells them that they're coming out of spinal shock? What's the doctor do every day? Goes in, stimulates the bottom of the foot, see if there's any reflex. And so then once that comes back in, then they're going to look at starting to get them up and getting them moving. If the sacral reflex arc remains intact, patient is said to have a reflexive or spastic bladder. Bladder empties reflexively when bladder has pressure applied. So these guys can actually help empty their bladder by putting pressure on their bladder. Every one of them is different. Because some, it doesn't matter what level they are, you'll have some that can do something like that and really get their bladder control under control because of that. Or you have some that may have a real low level and they're incontinent all the time. So they're going to use a catheter for sure. Conus medullaris or cauda equina injuries, what are those? What levels of conus medullaris or cauda equina injury? About an L2 and L3, right in that L1, L2. They have a flaccid bladder. So they need manual emptying, which means they're going to have to put some pressure on it to really get it completely. A spastic bladder is better because then it fluids, stool softeners, and manual stimulation or evacuation, which is not fun. That means someone's going in there to clean them out manually. So they want to avoid that because that's hard on your system to do that. But they do that occasionally. And normally it's every other day. And if people are, you can set these guys up to where they're fairly regular too, unless they get sick. Catherine, it won't matter. But most people have a regular bowel deal. The reason why they set it up for every other day is because it's so time consuming if you do it every day, right? But some of these guys probably do a bowel program every day because that's just, maybe their bodies react to that. Sexual dysfunction, and Kendall will cover this more in psychosocial aspects, and the only reason why I tell you this is they're gonna wanna know. And guess who they ask? Their physical therapist. They wanna talk about it with you, and they're going to, male and female. Why? Why do they do that with you?
Because it concerns them.
It concerns them, and they can trust you, and they don't know who else to ask, because they don't have social workers anymore, right? So they want to know, and they think, well, you should know that. So males with upper motor neuron lesions have potential for reflex erections with sacral reflex intact. The ability to ejaculate is limited, though, for both upper motor neuron and lower motor neuron lesions. Normally what you see them doing now is they're doing a lot of artificial insemination, and they're taking like a quadriplegic sperm, and they're doing a lot of art for the to do that. A lot of times when they have lumbar lesions or they're paraplegics, if they're a low-level paraplegic, like in the lumbar area, they cannot produce children. For some reason, it messes up their sperm. So it doesn't have a normal look to it. So normally those men are not able to produce children. But a quadriplegic, if they can get enough sperm, they can do that. And so they're producing a lot more babies like that. Women can just continue to menstruate and they can have babies. You can imagine what kind of problems that causes. And I knew a quad that was incomplete that had 4 children after she became a quad. So doctors do not like them to do that. It's very hard on their bodies. They go into, normally they'll do C-sections. They don't even give them a chance to deliver, although they can, because your uterus is a involuntary muscle, and it's controlled through the sympathetic and through the autonomic nervous system. They can go ahead and deliver a baby. Normally they don't feel anything, so they can't help push. But so normally they're going to do a C-section on a paraplegic or a quadriplegic mother.
They wouldn't have to put them out for that either, or a C-section?
No, well, you mean the mother put them out? I don't think so, because they aren't going to feel anything. I mean, they would if it was, depending on what level they are, as to whether a quadriplegic, no, they wouldn't have to do that.
Think how much money you save on anesthesia.
Yeah, just be a quad and have babies, right?
Problem solved.
Thanks.
Spasticity, you remember, goes with upper motor neuron. The prevalence is higher in patients with cervical and incomplete injuries. And remember, almost always now we're seeing incomplete injuries. I mean, not always. It could, if it's severed or something because the injury was so severe. But again, they're getting that swelling down so quickly, and we're seeing a lot of return. Spasticity can be beneficial or harmful to a patient. Sometimes they'll use spasticity to do their transfers, to stand on. And they learn how to kick it in and utilize it to get it out of bed and all kinds of things. Treatment is medication. They're doing a lot of spinal pumps now. They're giving them baclofen, I think is how they say that. Muscle relaxants, they do positioning somehow, in a wheelchair, if they're positioned a certain way, they don't go into such severe spasm. I've seen spasticity so bad that they had to tie their upper trunk down and their legs down, because if they didn't, the feet would come up and hit them in the face when they're laying down. The stomach muscles would be that strong, or else the leg would be down and the stomach muscles will pull that person up and they'd hit their face on their legs. So sometimes that's how severe it can be. And those people, for sure, they're treating. But when I first started doing this, they didn't treat you for spasticity. You just had to put up with it. They would give you like muscle relaxants, but that's about it.
Do they do Botox for spasticity?
They do, yeah. And they do it in CP kids also.
Well, I knew that they did it for, what is it, like contractors, there's a girl that I took care of, and she has a baclofen pump.
I think
in
that's
her
very good.
spine or whatever.
Yeah, and that's to decrease spasticity.
Well, it's for her contractor, she doesn't have any spasticity.
Mary Blair will be
she's
here
just-
tomorrow.
Okay.
Awesome. What is
Okay.
FES?
Functional electrical stim.
Oh, okay.
So they're doing all kinds of things. Surgeries also, if they have real severe spasticity, sometimes they'll go in and cut some of those sensory nerves motor nerves. There's all the different rhizotomies and myeloctomies and tenotomies, and so just going in and blocking it, and sometimes even cutting a tendon. So that would be the last. They don't really want to do that. That's not always a good idea, but they do that sometimes if it's that severe. But there's other ways to do it now with these pumps and things that they're utilizing, because they don't really want to do that.
If they did, I guess the cutting the tendon one, they did that to the girl that I was talking about, and her foot just turned completely sideways.
After they cut the tendon?
Yeah,
Oh.
the doctor that did it screwed it up or something.
Oh,
Yeah.
wow.
And her lost it or whatever.
Yeah.
Her foot just went completely.
The thing that you want to do is if you're a spinal cord injury, where do you get your surgeries done? Spinal cord centers. You don't let someone in Fort Smith cut on you, right?
Right.
So if you have a cerebral palsy child and they're fixing to have surgery, where would you have that surgery done? You go to Little Rock, or you go to Oklahoma Children's Hospital. You would not do it in Poto, Oklahoma, or in Fort Smith,
Paul said Moffett.
or Moffett, right.
The Moffett walk-in.
I thought they were starting to tone down the specialists and trying to make everybody general.
They are, but you better go for a specialist who
Where's
knows
the
exactly what they're
closest
doing.
spinal clinic around here?
I would say Little Rock is probably one of the best spinal,
There's one in Texas, isn't there?
yeah, they're, probably the very best is up by Denver, Colorado at Craig, call it Craig Institute. And that sometimes they'll ship people from here to Craig. And then there's a really good one in
Craig, Colorado?
Phoenix, Arizona. There's a good one in Tulsa, huh?
In Craig, Colorado?
No, Craig is the name of the hospital. It's
Oh,
in
okay, see,
Denver.
I've been in
It's-
Craig, Colorado.
I think
so
it's in
big.
Aurora.
Oh, okay.
It's right outside of Denver. I mean, it's right there in the Denver complex. And it's called Craig. the
There's a
hospital.
good one in Tulsa, you said?
I think there's some pretty good care in Tulsa.
That's where they have that laser spine institute at, isn't it? They have
Yes,
one there.
yeah, I think they do. And some of the things that you are gonna talk about in psychosocial aspects are just different things that they have to deal with. When someone becomes a paraplegic or a quadriplegic, just think about body image and how hard that is to deal with. I find that women do a lot better than men. They accept it, they kinda start getting into rehab and are kinda back into some type of life in about 6 months. Men take about 2 years before they kinda get where they accept it and kinda get back into where they have a plan, okay, I'm gonna go to school and do this. Or I'm going to do this, or whatever, they start making plans, and so that's just what I've seen in my experience. Again, what happens with families, it's very difficult to make that change. Sometimes, well, probably with your spinal cord injuries, I don't know what the real percentage is, but the majority of them are male. Unless you're in a motor vehicle accident, most of them are male.
Young males?
Yes,
Doing
between
crazy
16
things.
and 25, I believe, is the highest level.
3 weeks, Steve.
Passed all that, good to go.
They're just, the expectations for return of function, remember now, because so many of them are incomplete and they're getting that swelling down and getting them into immediate trauma care. We're seeing a lot of them walk out of the hospital that would have been completely paralyzed before. So that's fun, that's a lot of fun. They have to take care of their skin, just like Joseph having that bed sore 12 or 15 years down the line. What's happened to Joseph is he's pretty close to my age, so he's hit 50, or he may not quite, he probably is, he's probably in his 50s now, and so as they age, they have to remember that they still have to do their push-ups and keep themselves in good shape. When Joseph was first hurt, he could lift himself up from the floor. He's a T8 injury, so that's pretty high. And he could lift himself up off the floor into a wheelchair. He can't do that anymore. So he's put on a lot of weight. And so that's just something that as they age, you have to look at that stuff. And so he probably needs to get back to working out daily. And I'm hoping he's doing that. I haven't seen him in a year. Well, since that last football game. Respiratory issues, we talked about that so many times. That's what kills people. If they're a high-level quad, they have to quit smoking or they're gonna be dead quickly. But they don't always do that. So that's, and then we talked about bowel and bladder issues.
Would we ever have to do the valve?
No, no, but you know, you just need to be aware of it, because they're gonna talk to you about it. I mean, I'm just telling you, when you get work in rehab and you deal with spinal cords, you are the physical therapist, and they just trust you because you're teaching them how to use their body again, and that's just what happens. And so that's a good thing. So, okay, y'all go take a few minutes break, and then we'll go into the lab and